keeping an eye on imaging. Discussion and commentary based on articles from JACC Cardiovascular Imaging.
Hello, I'm Christopher Kramer, Associate Editor of JACC Cardiovascular Imaging, and I'm here today with Dr. Milind Desai from the Cleveland Clinic to discuss his paper that's upcoming in JACC Cardiovascular Imaging on the prognostic capability of late gadolinium enhancement in ischemic cardiomyopathy patients with reduced ejection fraction. Milind, tell me what gave you the idea to do this study.
This is a paper which was originally conceptualized to fill in what I thought was a knowledge gap in the field of cardiovascular imaging, particularly in the field of ischemic cardiomyopathy, from a viability perspective using the most accurate viability assessment tool, the delayed hyperenhancement in cardiovascular MR. The papers that have been published in recent memory basically looked at a spectrum of patients with or without known coronary artery disease, but from a risk factor profile, they were relatively of a lower risk with relatively higher ejection fraction. So we wanted to select patients who were the sickest of the sick with severely reduced LV ejection fraction, known documented ischemic cardiomyopathy, and to see how precise quantification of scar by cardiac MRI or late gadolinium enhanced MRI, how it helps in further risk stratifying such patients. Because all of us know that EF is a very powerful marker for survival or predictor of survival, and we wanted to see whether or not scar imaging adds incrementally beyond what is provided by ejection fraction in this very sick population.
Can you describe the patient population
Yes.
Exactly to us?
Yes, this was a study which included 349 patients with documented ischemic cardiomyopathy, which we define as documented severe ischemic cardiomyopathy, which we define as left ventricular ejection fraction less than 45% on echocardiography to start with, and all patients had to have at least 70% angiographic documented CAD or a history of myocardial infarction or a history of coronary artery bypass grafting to get into the study. So that was the primary entry point, and all of these patients were already referred for viability assessment by cardiac MRI.
And what were the clinical scenarios
Yes.
involved in these patients? Were these patients being evaluated for revascularization, et cetera?
Yes. We excluded, that's a very good question, we excluded patients in the acute phase, so patients that had undergone viability assessment in an acute STEMI or NSTEMI situation were excluded. So these were basically patients who were at least 30 days out of myocardial infarction who were being considered for revascularization.
What were the mean ejection fraction, age, and gender makeup of the patient population?
The mean ejection fraction was 24% in the group. They were 65 years in age, and about 70% of them were male, and vast majority of them were Caucasians.
Tell us a little bit about the MRI findings
Yes.
from this study.
Basically, what we found was that what we did essentially was two ways of assessing the scar burden on these patients. One of them was quantification of the actual percentage of scar vis-a-vis total normal myocardium, and the other one is what has been published in the literature is using semi-quantitative assessment of transmurality of the myocardial scar. So for all of it was done in the 17 segment AHA model, where we essentially, for the quantitative method, we used anything past 2 standard deviation from the normal myocardium as being abnormal for presence of scar, and we calculated a percentage of scar vis-a-vis total normal myocardium.
And what were the findings in terms of the prognostic implications
Yes.
of scar extent?
Yes. So what we found was if the patients were divided, we divided the patients into tertiles, and the patients in the lowest tertile of myocardial scar had the best outcomes versus the ones in the highest tertile. And there were 56 deaths or 51 deaths and 5 cardiac transplantations over a period of 2.6 years. And also on multivariable and univariable Cox proportional hazard analysis, what we found was that gender and scar percentage were the independent predictors, when even after including age, gender, ejection fraction, volumes, medications, revascularization, as well as device placement, ICD or CRT.
So as I understand it, the more scar and female gender were predictors of adverse outcomes in patients with severe ischemic cardiomyopathy and scar. Well, Melinda, thank you very much for the paper, and I think it'll be a great addition to Jack Cardiovascular Imaging.
Thank you very much. Thank you very much.
Keeping an eye on imaging.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.